fix. Okay, out. एंजियो कहाँ से होता है? एंजियो इन okay. So I will tell you for right injection. Huh? Right injection, please. Left injection, please. हाँ, wire introducer वो होता है ना, you can shape the wire. Push the wire. छोड़ो. ये कौन सी वायर है ये? What wire is this? हाँ?
Local floppy wire.
Back. Wire back. Back, 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 back. Yeah.
Will you like to keep the RC catheter in place or throughout, or?
Yeah, throughout, yes. You don't want to move anything because when you will move it, everything will move. So once it is there, because I'll have to keep cross-checking through the RCA catheter only. You get it?
And the initial choice of your guide was Sai, and what is the advantage of that?
Sorry,
Initially you decided to take another catheter guide, and then you opted for JR.
yeah, because that guide got spoiled. There was a dent in it.
Now, what is the advantage of that guide?
The advantage, it gives you better support. That guide gives you better support.
In case you want to go.
So, but RCA is not the main vessel, so I thought we'll change it to JR. So that is the thing. Otherwise, if I really want to do a CTO through the guide, then I will use SAL.
Dr. Goel, if you are just planning an integrated approach only, then 6 French guide on the right would have been.
Yeah, that's right. That's correct. But you don't know, when you have to change. So you be prepared for everything. That is the reason. When we do CTOs, we remain prepared for everything. Now I'll leave this wire here, pull this thing back, and trap the wire with a balloon. We need a 2.5 Oxford balloon. Trap this, and then I will put a crusade. I will put a crusade and try to do a parallel wire. Okay?
And the second wire choice would be?
Let me see, maybe I'll use a Conquest or something, or wire 2. कोई Oxford balloon 2.5 to trap.
2.75.
Crusade.
Keeping this balloon inflated
Doesn't make a difference.
Nah, the pressure transmission would not be there. That is one issue. And secondly, whether there can be any thrombosis because of that?
No. That is all heparinized. No? Tell me when it is 1 hour. You have to tell me when it is 1 hour after heparin. Then we have to give 2,500 more.
Thus, keeping this balloon inflated will keep the wire in place.
Yes.
Proximal cap. इसमें कौन सा सबसे ज़्यादा इम्पोर्टेंट लगता है तुमको? Of all these 5 scores, ये सीख लो. that.
लेफ्ट इंजेक्शन करो जरा करो कहाँ है थोड़ा टेबल अन लो कहाँ है ये बैग अभी आया नहीं आया इसके अंदर आ रहा है ना आ रहा it is coming it has reached here टर्क यहाँ लगाएंगे हाँ
double lumen catheter. You can take another wire parallel to that, and then you switch the angle. What false lumen mode. Current now? Yes, I just put on this, and then we are going to another API.
right injection come on
Movement of the tip suggests it is in the lumen, no?
yeah looks okay looks okay so I have to do it a little more I have to do it a little more there we go I need the trapping once again ये क्या रह गया है वहाँ हाँ
There is a coiling of this wire. It was buckling at that place, so
that is the issue okay New York Sion
what is the advantage of this Caravel over microcatheter?
the Caravel is also a microcatheter 150 that is the only one we have so we'll use that
Any advantage?
it is actually thinner than a Corsair the entry profile is slightly smaller than a Corsair
So your crossing the micro channel would be easier.
हाँ direction. Cranial करो. Make it cranial. No, going too far back. Angio करो native वाला. Just hold on. Just hold on. Just hold on. Just hold on. रुके रहो. करो. Come on. हाँ. No. LAO. Make it LAO, please. Dry gauze. Make it LAO. ये भी back जा रहा है. It is not going in the correct direction. What view is this? RAO 29 caudal. Can we get back into RAO caudal? Leave it. छोड़ो. Angio करो. This one looks better, huh?
Dr. Goel, please explain the characteristic of this wire to our.
You see, SUO3 is a. It has that composite core at the tip, so you can direct it. It is self-shaped and it is tapered and from Asahi, and it has a 0.3 gram load. It is very soft. Okay, so it is very good to traverse the collaterals, especially the narrow ones like this one. This is narrow.
Yes.
So let us see. I hope that it goes in properly. Let's see.
Dr. Goel, do you use this thing, CT angiography for this CTO procedures prior to this? How frequently?
Not much, I would say. Not much, but yes, if there are long occlusions and you don't know the anatomy, then you can use it. No, that's not right. Huh? Seems to be in a different branch, huh? Yeah, that's right. अपना इसमें बैग लीड तो है. अपना सुओ हाँ. क्या छोड़ लो सुओ हाँ. Pure contrast. ये है pure? Keep it here. Okay. Give me a Gaia 3 wire. We have a ADR also here? Huh? No. हाँ हाँ. गाया 3 वायर दो. एक बार जाता है तो ठीक, नहीं तो.
Would you like to remove the caravel from the RCA? No.
नहीं, let it be there. Let it be there. गाया 3 हाँ. When did we give the heparin? अभी टाइम क्या हो रहा है?
It's 2:30, sir. There, sir. There is a time.
कहाँ है?
This one, सबसे नीचे.
Okay. What time did we give the first heparin? What time did we give the second heparin? ये क्या है? गाया 3.
This is Gayatri, sir.
हाँ.
it's going outside. So 1250 and 150.
150. Okay.
No,
देखो कहाँ आ रही है वायर. आया?
no,
It has started coming.
it has come near. Yes,
हाँ.
it's coming now.
Now. कर कर.
Yes.
हाँ.
What is your plan now?
You see, I'll do a balloon dilatation in the proximal LED towards the septal.
Okay.
Because if I have entered the septal, that means I am okay till that level.
Proximal, yes.
And once a balloon track is created, a small balloon, 1.5 or something, then I will put a crusade on this wire and try to enter the rest of the LED integrator. You get it? Maybe it will start flowing already. If I am already across the CTO, it would already start flowing. So we'll see. ये क्या कर रहा हूँ मैं? ये क्या है?
So this is the trapping balloon, sir.
This is a trapping balloon. नहीं तो हमें क्या
तो
करना?
पार्ट दिएगी ना सर का?
एक सेकेंड. फ्लोरो, हाँ. So this is a trapping balloon coming. इधर क्या है? What is the? It is coming in. When it comes, you tell me. It has come. Trapped. Trapped.
Trapped, sir.
Okay.
You could have pushed the crusade, it could have served the same purpose.
Which pusher?
Crusade you could have pushed.
No. Crusade ही को निकाल रहा हूँ. I'm pulling out the
वो हम
crusade.
समझ गए, लेकिन उसको 1.5 बेलून को छोड़ के अगर उसको पुश कर देते, you could have created a channel there.
No. Crusade is not a coaxial catheter.
Okay.
It has two lumens. It cannot be pushed forward.
On this Gaia 3, I am saying.
No. So then it has its side hole will go eccentric. Okay. What is this? Trapping. Now give me a 1.5 New York balloon.
So 1.5, 15, fine.
हाँ.
আর একটা insufflation device দে.
Fix. 5 cc? No. 5 or 10 cc? No. Dribble. Dribble. Stop. Negative. Okay.
Will a allocranial injection help integrate?
No. Allocranial you will not make out much. Because here I can make out that there is till where I am, and I have to retry more.
So you'll keep the microcatheter tip at
No. What I'm wanting to do is I want to change this wire to a softer wire and then do crusade. You understand?
Okay.
कहाँ है? Back. Back.
So for this tracking the distal segment of the CTO, will you take a hydrophilic wire or a non-hydrophilic, which will be
अब
better or safer?
देखता हूँ, let me see. अभी तो I'm trying to put a AP caudal करो. Do a AP caudal please. Do a AP caudal please.
Will you take a straight tip wire here or
No.
small bend?
No. Bend will always be there. You cannot.
Very small bend.
Small bend. Yeah. दिखाओ. Torso. डालो. छोड़ दो. आ रहे हो करो. आ रहे हो. Cranial. कहाँ फिर वहाँ पर नहीं चाहिए. आ रहे हो cranial. Come on. आ रहे हो injection. Right. This is okay.
You are in there.
This is okay.
Yes.
This is okay. हाँ. Finally, I think यहाँ we got it. छोड़ दो.
Yeah.
Right injection. Come on. Yeah, that's fine. I think you've done it. So we tried everything. Lie. So now with this here, this is a crusade. This is a crusade. Just hold on. Where is it? Unlock karo. Okay, just hold on. We should not lose anything. This is this. Okay. So now this wire stays where it is. I'll get that back. Okay. Okay, balloon please.
10, 12,
15,
14,
down,
15.
down. Balloon,
6,
down.
8, 10, 12.
Balloon,
16.
down. Balloon, down, down. Once I get antegrade flow, then I will remove it. There's some, because unless you sometimes you don't get flow, then there's again a problem. So we must ensure that you get antegrade flow, then you remove the contralateral. So 1 second. Left injection. Come on. 1 minute. LAO please. LAO. Just hold on. Back to RAO cranial. Come on. Inject. चलाना. It has, we'll change the wire. Remove the trapping, micro catheter. We'll change this because with this wire you can't see. Trapping. This 2.5, na? Confirm. Huh. Ah, okay, come. Trap. Okay, micro. Ah, 130. 150 is only when you are going to the retrograde channel.
Using dock extension for this.
You can use dock extension, but you know, to keep connecting it all the time and removing it, you sometimes bend the distal end, and there is a big problem.
Now, once you have connected, keep it connected. The
Then
assistant will have a problem.
maneuvering becomes difficult. Fix. You should hold it actually. ठीक है. Detrap. Unlock.
Although you have placed the ostial position of the stent is quite well, but you have done only in one view.
No, this I will talk. I can talk to you more about this.
Yeah.
This view is the best view. What I do is actually I put two wires. I could have done that. I put a wire in the circumflex, and I put a wire in the LED.
And then you can see the ostium clearly.
Yes, and then from the proximal end of that stent, you leave a gap. Negative. You leave a gap. Balloon. You leave a gap which is about the width of circumflex, the diameter of circumflex. Okay?
Yeah.
Balloon. Low pressure.
Now that the diameter of the circumflex is known. Yeah.
So when you are doing a stent in the ostium without a wire in the circumflex, you have to remember from the previous image as to where the ostium was. But if you do this technique of putting the wire in and then doing it, you have this as a landmark all the time when the stent is being placed. ये देखो, अब मैं आपको स्टेंट दिखेगा उससे लाइव व्यू से, एंड यू विल नो दैट द गैप. ना इसका वो कराओ, बूस्ट कैसे होता है, मिडिल वन लीव. Now you see the proximal end of the stent.
Please focus on this camera.
उसको दिखाओ. Proximal end of the stent, the gap between the proximal end of the stent and the circumflex wire is exactly the width of the circumflex in this view, in this magnification on this frame.
Yes.
So I have become so used to it that now I am doing it without wire sometimes. But I must have done at least 300-400 cases like that with wire there. Actually, I have also written this up as an article, but it is not yet published. But you see that?
Yeah.
It's
very clear.
And this is the best way to put an ostial stent. So several people, when there's ostial disease, they want to put a left main to LED and all that. I don't do that. You see, you are, for no reason, making it more comorbid by getting a left main inside it. Why? Place the stent in the ostium, but then you have to be exactly at the ostium. You cannot be inside in the left main, and you cannot miss the ostium. So this is how it is. Now you see how. So this is post facto. I have shown you that it is there only. You can confirm it on IVUS, you can confirm it on OCT, but post facto this is it. You get it?
will keep if keeping a balloon in the circumflex, will it help further or no?
No, 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 no. I don't, because circumference we have not touched.
So
सर हाँ इसको कर दो, ठीक है ना? करो 3. हाँ 12. We are just increasing size 14. We don't want very high pressures. That's fine. Down. Okay, यहाँ भी कर दो थोड़ा सा.
2, 4, 6, 8.
10, 12, 14. बस down. I think that's enough. आगे 3 रहेगा. ठीक है? I think this is done. एक बार डिस्टल कंफर्म कर लेते हैं कि it is okay. अब देख लेते हैं, see how it is. So 180 caudal, आइए. Angio, come on. Inject. 1 cranial. Come on. I think it's fine, we can accept that. Huh? चलो, good. Okay भैया, thank you.